Good morning, everybody, and welcome to the NHS England Board. We are live streaming this, and to everyone who's joined us, members of the public sitting at the back of the room and people who are watching this online, you are very welcome, and we look forward to a good and constructive discussion this morning. Before we get going, I will do a quick run round the table and have everybody introduce themselves, not least because we have a number of new people. We're moving towards, we've got a number of new non-executive directors, but also we are moving towards a number of interim posts in the new combined structure. That's across NHS England and the Department of Health and Social Care, which was announced last week. And so I think important for everyone who's both here and watching online that you know who everybody is. So, Ravi, we'll start with you.
I am Ravi Gurumurthy, just joined in my day job. I'm the Chief Executive of Nesta.
Good morning, everyone. My name is Tom Cowell. I'm the National Director for Learning Disability and Autism here at NHSE.
Good morning, everyone. Chris Gormley, Chief Sustainability Officer at NHSE.
Good morning, everyone. Habib Naqvi, Chief Exec of the NHS Race and Health Observatory.
Good morning. Diana Day, Director of Healthcare Inequalities Improvement.
Tom Cavassi, Executive Director of Strategy.
Glenn Burley, Financial Reset and Accountability Director.
Mark Bailey, Non-Executive Chair of the Digital Data and Technology Committee.
Claire Fullen, National Medical Director, and I'm the National Priority Programme Director for Neighbourhoods.
Morning, everybody. I'm Louise Ansari, one of the new non-executive directors, and also the Chief Executive of Healthwatch England.
Good morning, everyone. I'm David Probert, Deputy Chief Executive.
Morning, everyone. I'm Rob Checkett, Strategic Advisor. I'm in charge of comms and engagement in NHS England.
Good morning. Paul Corrigan, new non-exec director.
Duncan Burton, Chief Nursing Officer and Interim National Priority Director for Maternity, Women's Health and Children and Young People.
Andrew Morris, Deputy Chair.
Penny Dash, Chair, NHS England.
Jim Muckey, Chief Exec.
Morning, Elizabeth Omani, CFO.
Shelby Townsend, and I chair the Audit, Risk and Assurance Committee.
Morning, everyone. I'm Ming Tang. I'm the Interim Chief Digital and Data and Information Officer.
Morning, David Bennett, new non-executive.
Morning, everybody. I'm Sarah Jane Marsh, National Director of Urgent and Emergency Care and Operations.
Sam Everington, a NED and a GP in the East End of London.
Good morning, Meghana Pandit, National Medical Director.
Robert Leckler, I'm an old NED and I chair the Quality Committee of NHS England.
Mark Cubbin, I will be the National Priority Programme Director for Planned Care.
Morning, Suresh Vishwanathan, Associate NED and also on the Digital Data and Tech Committee.
Hello, I'm Jo Lenihan, Interim Chief Workforce Officer.
Morning, everyone. I'm Carolyn May. I'm Director of Leadership, Talent and Management Development.
Good morning, everybody. Lindsay Hughes, Director of Research, NHS England.
Good morning, everybody. Alex Churchill, Deputy Director for Policy for Clinical Trials from Department of Health and Social Care.
Okay, thank you, everybody. And I will obviously have to be on my toes with so many people around the table to keep us to time. Just before we start, we've got apologies from Amanda Doyle, who leads for primary care, and Vin Diwakar, who leads on transformation. And I would like to say this, Suresh, who is our Associate NED, this is his last board meeting, and I'd like to say a big thank you for all that you have contributed to this. We do have a declarations of interest and the register is published on the website, and I would ask whether anybody has anything which isn't on the website that they would like to declare today. Okay, thank you very much. So I'll get us into the agenda. First substantive item is the minutes from the last board meeting. Does anybody have any comments on those? No? Okay, so we'll take those as an accurate recording of the last meeting. We'll come on to some updates from board committees. We haven't had as many of those. Just to be very clear, we are, because we've got a number of new NEDs, we are moving into the new committee structure, and hopefully at our next board meeting we'll have more updates from the various committees. But we do have an update on audit and risk from Jeremy.
Thank you, Penny. Just quickly, we met last week. We are making good progress on our risk register and mitigations, and increasingly working with the department to bring the risk register together. And the same with the internal audit plan. We've got an update from the internal auditors, but also on how they're working together with the DH internal audit team to bring the plans together. We took an update from Gus Williamson on the primary care support services systems, identified a number of risks, and a paper on that topic is going to come to the executive to give it a bit more profile and make sure we've got a plan for transition over the next 2-3 years. Really good progress from the executive on open audit items. It's a bit of a canary in the coal mine in terms of the overall culture. More to do there, and again, an issue for the executive to look at, I think, as to how particularly the priority ones can be resolved. Good progress from the team on getting the accounts out. It's quite a challenging situation and the audit requirements have changed, but good progress on the NHS England accounts, and they should be coming before the board in early October, and the provider accounts hopefully shortly thereafter. And then finally, we are about to move on to a new accounting system. It's going to affect the whole system, ISFE2. We're all holding hands together and hoping it all goes well, but I think the team have done a really good risk assessment, contingency planning, communication into system, and well done to everybody being involved in that. It's a mammoth effort. I think most of the team are up in Leeds now trying to make sure it goes okay. So well done to Elizabeth, Vicky and the team for that.
Okay, thank you. Any questions, Paul?
I was at the committee, and when we get the risk register, I'd just really like to draw everyone's attention to what was one of the main risks and the mitigation for that risk. And one of the main risks is we're too slow in bringing about the change. And so I think one of the things we need to keep in mind is whether we are making that slower or quicker. Because if we're making it slower, we make the risk greater. So the mitigation that we'll be looking at through all of our activities is, are we up for the pace of change?
So can I suggest that we come back to that when we discuss the 10-year plan update? Because I think that's the moment at which we should really be scrutinising, are we doing enough, are we going quickly enough? But is your question, Paul, also to Jeremy and Elizabeth about are we capturing the risk of that accurately?
I think we were in the committee, in the risk committee. It's just that when you come out of that, I think the conversation we had is that most people's experience of risk is change. And when we say the biggest risk is not changing, that for a lot of people is counterintuitive. It's true. Actually, it's true at the moment. The risk for the National Health Service is not changing fast enough. Well, I think most people experience risk as changing too fast.
The comment you made, Paul, in the meeting was the risk is that in the system, in hospitals and GPs, the risk that we're planning to take will be seen as being risky. And so we just need to be careful as to how we communicate, how we get the message across, and how we deal with that potential barrier to change as we're trying to deliver what we're trying to deliver.
Absolutely. So key point, and let's, as I say, keep hold of that for when we come on to talking about it. Elizabeth?
Yeah, Penny, just to echo something that has just been said, really, and this ISFE2 system, so it's a new cloud-based system for finance and accounting, and it's just a thank you actually to all of the financial control teams out in the wider NHS, because it's 42 ICBs, it's HSIB, it's all the CSUs, and it's NHS England. It's been a couple of years in the making, and yesterday we made the decision that we were ready to proceed with a go-live date effectively of the 1st of October. So it's a huge amount of work, and a lot of people working long hours and over weekends. So again, to those financial control teams that are finishing accounts and then moving quickly into this work, just a massive thank you, because some of them are part of a change process as well.
Okay, thank you. And yes, we would echo that. Okay, so that's quite a nice then link into update from the Digital and Data Committee, Digital Data and Technology Committee. And Mark, perhaps you might like to also reflect on the point that Paul's raised, because this is one of the areas where sometimes we look at the risks associated with adopting new technology, but we don't look at the risks associated with not adopting it. So.
Of course, Penny. So the DDAT met yesterday. Some really good progress in some areas. So progress on cybersecurity across NHS England and the resilience plan that the board's been pushing on for 18 months is good. There's clearly quite a lot more work to be done in the system and in particular in the supply chain, which I think will continue from here. I think the team working on the single patient record should be congratulated. 3 options are now in proof of concept build, so no longer in PowerPoint, but actually in practicing code. I think that brings home we need to start doing a lot more work on the engagement plan that goes with it, because to your point about things that need to be adopted and will be changing for the whole system, the single patient record is a massive vehicle for change and needs to be delivered. The NHS app continues to go from strength to strength. If you look at the adoption, unique users, monthly logins, it's probably, and I need to check this, the most used app in the country. There is absolutely clear use cases for managing access, managing treatment paths, and also driving prevention. I think the key task at the moment is to select a small group of really high impact cases where we've got clear clinical sponsorship, which is something I'll come back to, which can deliver both improvements to patients and productivity. And I think that list is there. I think we just need to get to the shorter list and start executing. The operating model work for the combination of the department and NHSE is going well, and I think we'll have a substantive proposal by the next meeting. I think if there's one theme, and it comes back to what Paul said, consistently there seems to be a lack of sort of operational ownership and vision driving the technology team harder. And what I think that's causing is us slowing down. And I think if you look at the need both to reduce waiting lists, to improve performance in UEC, access to general practice, improving prevention, technology is the answer, and we need to drive the adoption much faster. And the risk of not adopting it is we continue in the position we're in today.
Okay. Before we take questions, Ming, anything you'd like to add?
No, we had quite a long debate yesterday on how can we align better and work better in a matrix form between the technology teams and, the clinicians and also the ops teams, which we are starting to do. We've had some really good engagement and workshops, but it's the starting of the journey rather than the finish.
Yeah. And on the single patient record, so good to hear that progress, Mark. What's your sense, neither of you, when will we have it?
Which day?
What time? I'm happy to go with a quarter of a year.
We should have a prototype ready for review kind of end of this calendar year for adoption and further development, to be honest, because we will then have down selected to hopefully one pattern that we want to deliver. We're not really going through this as we will buy this. What we're really looking at is what's the concept we're trying to achieve, and what's the modularity, how much of it have we already got, what do we actually add to, and then how do we accelerate the change. So in all this work, as Mark said, we want to find the really great use cases that we can drive through and make sure that it does all those things, because we're going to iterate this over time. It's not going to be one quick bang and it's done.
Okay. All right, thank you. So I've got Robert, I've got Louise. So we'll take, and Suresh, I'll take all 3 questions first and then come back to Mark.
So it's more of a comment than a question, but I think, as Mark said, I think the progress is terrific. But the point of these technologies is to enable pathway redesign and productivity gain. And I think the conclusion we came to is that a great opportunity to build these technologies, for example, single patient record, into pathways is the modern service framework work. So that's where you begin to see how you can re-engineer a pathway a whole pathway using these technologies.
Yeah, we might come back to that and talk about partly modern service frameworks, but also all clinical pathway redesign. Suresh?
I just wanted to add that really productive session. My observation is that there is a lot of measurement technology that's built outside of the NHS, watches, wearables, rings, pick your favorite. I think our vision should be bolder and braver to encompass what's happening in the outside world and bring it back in, especially as we are focusing on prevention.
Okay, Louise?
Yeah, thank you. So it does absolutely seem like fantastic progress, and we know that people really, on the whole, welcome using the app. Can you tell us more about how you've involved service users in the development of it?
Okay, so go on, Sarah Jane, do you want to go?
Just to totally, because we've had a really productive meeting, didn't we, Mark, Ming and I, about what we might do on UEC here. I do think we need to acknowledge that for many of us, we don't really know the art of the possible. So if we're waiting for I know we're not, but if we were to wait for the vision to just come from current operational and clinical leaders, I'm not sure it's there. It's got to be the meeting of the genesis of the art of the possible with the tech teams to really drive ourselves forward, because I think a lot of us start to invent or start to work on what was last year's technology, not the technology for 3 to 5 years. So we need pushing on. So we're all up for the challenge, but I don't think it's as simple as we just have a clear vision and then off we go and try to implement it. We need to be really pushed, I think, by the tech people in terms of what will be possible in a few years' time.
Okay, so I'll try and weave all these together. So there's essentially, in some ways, a similar question about how do we really get tech embedded into all services and do that both in a push and a pull. So we're not waiting, as your point, Sarah Jane, for staff to say. It's about how do we say these are good ideas, let's start trying them. How do we really, at Robert's point, adopt that into all of our care pathways, whether they're modern service frameworks or other care pathway designs? How do we involve users as we're developing different products? And then how do we open up the app, which was part of the 10-year plan, to be able to, for people to put in their own data from wearables and other devices? Ming? Or you can ask Mark.
So I think we should pick up, let's deal with the user input, because I think the app team are one of the prime example of.
So we actually have a bank of about 25,000 people that we test the functionality of the app with, and that's done on a regular basis, just as routine. Every kind of feature that they change is actually tested with that bank of users. So it's quite a lot of engagement, and then there's local engagement as well.
And then on the sponsorship, I think in all periods of change you get these slight dislocations. I think Sarah Jane's point about the meeting with UEC, what the technology can do, what the vision for UEC is, I think we need to mirror that. I think similar work's been done on outpatients and cancer. We need to do the same thing on primary care, but pulling the business closer to technology and technology closer to the business and actually creating this art of the possible and some pace, I think, is the key. And I think collectively everyone on the committee, this is no longer a technology challenge. This is a business change challenge. The tech can be done. The progress made on single patient record in 6 months has basically proved we can do this. It's now a question of execution.
Okay. I think we might need to come back to this, because I think there is a bit about how do we up the ante on it all. What's the best way of doing that? So maybe we take that offline and have a think about how to do that. Take some specific things. And then wearables into the app.
There is some experimentation already being done on wearables. I think, again, the standards are there. We just need to decide where we integrate it. Is it with a single patient record? Is it into the app? And then how do we hold that data and how do we curate it? So it's not the technology's there, it's the usage of that and how we want to use that to change pathways, really.
Okay. All right, good. To your bit, Louise, we should have a board meeting up in Leeds sometime soon to make that happen. And there's a whole team there of people who do some really cool stuff with tech, and you can go and try it yourself. And really interesting, particularly about looking at people who find it harder to use tech. so we could go on a board visit and actually test out some of the stuff that they're doing live. Be a good thing to do. All right, good. Let's move on to performance. So we have a very detailed performance report. This remains working. Oh, sorry, I jumped over Jim.
That's fine. Yeah, honestly, skip past it.
Sorry, Jim, your update first. Thank you, David.
Just very briefly then. So September's always, it feels very chaotic. It's always very busy in the national system. We've had a busy couple of weeks in terms of public accountability, Public Accounts Committee, Health Select Committee, stock takes with the Prime Minister, various other things which are all sort of scheduled, but at an important point of the year when we're starting to think about how we'll land this year, how do we complete this year as well as we should do, how do we navigate a tricky winter, etc. They've crystallised a few things for us to really focus on, which we're working on over summer as well, which we'll touch on in a second. Lots of progress in our operating model, and we've appointed chairs of cluster ICBs, chief execs, soon to be announced as well. We do have a tension in all of this about the voluntary redundancy scheme, which has been well publicised and in a pretty long awkward conversation with Treasury colleagues about it all, just trying to unlock that. And at some point in the next couple of weeks, if we've not managed to land that, we'll have to work through a plan B option to allow our ICB colleagues to move on, and similarly within NHS in NHS England. But a lot of really good work there. Also, the work led by Glenn and colleagues on the oversight framework, I think, is really taking shape. It's that and the weekly tables that are sent out, etc. Common discussion points now in the service. Absolutely not fixed yet, so still a lot of refinement to do, but fantastic progress. Also through summer, which we'll touch on later on, we've done a lot of work with colleagues in the service and across government on bringing the 10-year plan to life. So what we're really trying to do, is we set out in the letter at the end of last week, is get the balance right between short-term delivery, landing this year on our financial and operational imperatives, but start building the future. Going back to some of the points raised earlier on, there's a really difficult balance we've got to strike in all of this between being really ambitious but not making it break. So in the same sentence, we can talk to colleagues who want more change, more rapid change, but are saturated by the amount of change that's already going on. And that's just a live dynamic that we're all trying to manage well together. It feels like a long time ago since we had our last board as well. And if you remember, the main dominant issue in that board was industrial action. And I think it's fair to say the service, led by colleagues here, but right throughout the service, did a fantastic job managing a difficult set of circumstances and really minimising the amount of disrupted activity. That said, we are a little bit off track on some of our metrics as a consequence, but really significant progress over previous rounds in terms of maintenance of activity levels, and a lot to learn from in that if we do have to go through it again. And then I'll come back to Mark's point and challenge on the tech. In those processes I've described, the public accountability sessions, etc., our work with the service, great chief exec session last Tuesday, there are two standout things we have to unlock. And technology is a part of the solution. Outpatients is the thing we have to unlock. We're just having another go now about how we get into that, but it is the thing that we have to find a way forward on. And also how we change our service model to uncrowd our EDs. So I started the day yesterday with the Society of Acute Medicine in Manchester, ended the day with Penny, with the President of the Royal College of Emergency Medicine. Wherever you talk, whoever you talk to, there's a lot of tension in that system, and technology, new pathways is probably a big part of the way out. So I would say if we're looking for things where there's a really strong operational and business imperative to bring technology to life, they are probably the two things for us to focus on. And then just very finally, I just want to say, we'll say this all the time, and it's really true. Last Tuesday's session was really fantastic. We are trying to work with the service, alongside the service, keep everybody with us, keep everybody as motivated as they can be, but realistic about what's possible. The leadership response right throughout the NHS so far this year has been absolutely fantastic, and we as a board really need to try and nurture that, develop that, and keep it going through this, what will be a tricky period. Winter's always a tricky period for the NHS. So I'll stop there, Penny. Happy to take any questions if there are any.
Great. Questions for Jim? Yeah, stunned everyone into
David.
Back to David. Just before that, just because we've got a couple of minutes, I think what we'd say a bit more, Jim, about that working with the chief exec community, because there's a few things which really struck me. One is that you are including GP leaders in that group, which is really crucial. Not something that's happened historically, but it's obviously a really important part of the healthcare system. And the second bit is that you are asking amongst that group, of the leadership group essentially of the NHS, to work with colleagues here to develop proposals, whether it's for neighbourhood healthcare, whether it's for outpatient redesign, and so on. So just say a bit more about that.
So I'll bring Glenn in a second as well, who's led a lot of this, the work stream work over summer. But we are absolutely trying to work together alongside each other rather than in a hierarchical way. It's partly a recognition you can't run everything centrally, this kind of size of organisation or system. There is and colleagues have really stepped up with that. So whether that's 10-year plan, work streams, and bringing IHOs to life, neighbourhood care to life, etc., etc. We are also getting a lot of people come forward all the time with ideas, suggestions about other operational issues. So wherever that happens, we're just trying to go where the energy is and keep people involved. And there's some practicing chief execs in the room as well. It minimises the risk then of us thinking we're solving problem A and it's actually problem B, or if they find a solution, when you see it on the other side, it actually doesn't fix the problem. Partly recognition of it's just very complicated. There's an awful lot of complexity out there, but that's really worked. I started the day with a conversation with a chief exec who told me quite clearly we're not going fast enough on IHOs, which is good, so there's good, healthy challenge out there, and we've opened up an awful lot of channels for all of us to have those conversations.
Okay, and just one thing, particularly because we're holding this in the public, IHOs, integrated healthcare organisations, concept of saying that a single provider could provide a broader range of services across the acute spectrum, including primary care, community care.
And taking whole population risk for that population.
I'm still practising as a chief exec after 9.
You're getting better though.
Every day in every way. The engagement has been great actually. And we've basically, anyone who put their hands up at the previous chief exec session, we've brought them in, and it was great to have the GP leaders there too. And then also, I don't think we're turning down any other option to engage. So Mental Health Chief Execs Forum last week, etc. So everyone was really enthusiastic. They also like the fact that we're going to them with a rough set of principles that they are enhancing and adding to. It's not us giving an answer and engaging. It's about them co-producing it, and they really welcome that, and that will continue.
Right. Rob?
Thank you, Chair. I think the leadership being shown by the chief executive community now replicated in the other professions, it's really starting to create a coherence across the service. So Elizabeth, I think you brought the FDs together for the first time in over 6 years. We've got the chief operating officers coming together in October. We're doing the same with the communications professionals. So that coherence that's been driven centrally by the chief exec community, the GP leadership, is kind of echoing in each of the different professional areas, and that's I think creating much more ambition out there in the service, instead of waiting for a policy or a strategy to tell us how we need to do something. You've got a lot of folks coming forward with really innovative ideas that perhaps we haven't thought of that then start to lead the way in terms of what we're doing. So it has a multiplier effect across the whole leadership community.
Great. Good. Right, let's go on to performance. So there's a lot in here. I think, presume everyone has read it.
86 pages, I can take you through.
No, thank you. And I know we've got quite a lot of questions and comments, so, but do you want to do a quick intro?
Yeah, thank you very much, Chair, and thank you colleagues who have helped develop this performance report, colleagues around the table, many of whom we've interacted with. So just a brief reminder, and then I'll just perhaps touch on some of the areas of improved performance and some of the areas that perhaps a little bit more challenged. Noting, as always, that my colleagues around the table are the real experts in each of these areas and delivering some of these key metrics. So first and foremost, we have adapted the structure to focus on 6 key areas: improving health, reducing inequalities, effectiveness and experience of care, patient safety, people and workforce, all of the access targets, and finally finance and productivity. And you'll see, different to the last time we met as a board, we focused particularly with board advice on areas such as primary care, maternity, community, cardiovascular, diabetes and prevention. So there are, and we'll see in the next item, but we can perhaps gather it in the same, where there are areas we can look to improve on and develop these metrics, and we are keen to. But noting, as I just said there rather flippantly, we're at kind of 86 pages. So the key thing is how do you adapt it? How do you make sure it feels real and live and we don't swamp people with paper? The other thing the team are doing, and a big thank you to the performance team who have worked really hard to pull this together, is seeing how we could use statistical process control a bit better so we can really look at themes and trends in a way that perhaps this report doesn't necessarily pull out at this stage. So if I could just take you through a couple of areas particular of highlight in terms of improved performance, noting that most of the data here completes to the end of June, and in some cases where we have complete lockdown data, we have it in July as well. So breast cancer screening, obviously an important part of our overall objective, is returning back to much higher levels from the pandemic. The number of inpatients who are autistic or having learning disability is reducing, which is something we'll pick up, I'm sure, later on, but has been a big area of focus. There are a number of key metrics around general practice with which the service should be very proud. Firstly, access to first appointment, which continues to improve. Secondly, the percentage of patients who are describing booking their appointments as easier or easy, up to nearly 75%, which is a record in terms of the levels of performance we have. In urgent and emergency care, which I'm sure Sarah Jane will pick up later on, we've seen improvement continuing in CAT2 response times, which we know is really relevant, particularly as we enter the darker and colder months. And finally, in areas like children and young people, particularly with focus on mental health services, we are seeing a much increased improvement with regards to access. Community mental health more generally, the access rate as well continues to improve, which I think matches the commissioning intentions and the good work that many providers have put in place. So there's a lot more that we should be very proud of, and we should congratulate our colleagues out in the service who are working really hard in all of these areas. There are, however, a number of areas where performance remains challenging, and these remain our priorities of focus. I'm sure Mark will pick up particular areas of elective and cancer should we raise, but actually some really good areas of improvement in many of those particular areas. But the percentage of patients waiting over a year for community services is something we have focused substantially on of late, because that isn't going in the right direction at the moment. This is an area of priority, and in the early data that we started to see most recently, this is starting to change and improve, again with the way we commission work, but this is an area of significant concern. The percentage of patients waiting with suspected autism over 13 weeks continues to be an area of concern, and running the regional performance reviews, this is an issue in almost every region and is a significant area of priority for us. Cervical screening, again, continues not significantly, but is not perhaps making the steadway forward that one would hope. The percentage of mental health beds that are out of area continue to concern all of us, particularly those of us looking after hospitals where we know we're not able to offer the type of care we would always want to colleagues with mental health. And that includes mental health trusts where length of stays over 60 days are continuing to not decrease at the rate that we would like to. So this is the latest set of operational data. What we are aiming to do, Chair, as I mentioned earlier, is refine this so we can get better trend analysis. You'll see at the end of each of the pack there are further areas we can look to include, and welcome colleagues' views on that either at this meeting or happy to take comments outside of this meeting. We're also thinking about how we deep dive on each of the performance reports. So not at length, and we may do this through subcommittee, but for example, we know that the work that Duncan is leading in maternity has a performance impact on every region and every system. Is that an area we would like to deep dive on? Sepsis is an area where we're continuing to focus energy and actually seeing some really impressive areas of performance. Is that an area to deep dive on? So those would be perhaps the questions I'd end with, Chair, but happy to take questions, as I know my colleagues would be as well.
Okay, great. And thank you, Dave. And I know we'll have lots of questions. I might just kick off with a couple, but if you keep a note, I'll keep a note, and then we'll go round. I mean, I think you didn't emphasise in the sort of areas for improvement overall health. And page 7 for me is actually probably a really important page, which is declining number of years lived in good health. Really worrying to see that. We know it's happening, but it's just worrying to see it that starkly, and that feels to me like that's a metric that we should be... I know that we're not going to see it change week on week, but we need to continue to look at that. And then, you know, as you pointed out, some of the other things in there, cervical cancer screening is not where we want it to be. Immunisations, MMR, is not where it needs to be to support population health. And indeed, across all of these metrics, we know that we have considerable variation. And we'll come on and talk about inequalities later. Exactly as you say, we should have a big focus on maternity care. We've got a lot of really good data there, and I think really helpful that we bring that a bit more into the public domain to do so. So those are the ones from me, but I know colleagues have got others that they'd like to raise. So I've got Ravi, I've got Louise, I've got Duncan, I've got Andrew. I'll take those 4 first. Ravi?
So a couple of points. Firstly, just picking up on your point about the average conceals variation.
Yeah.
I think it'd be incredibly helpful for all of these to show the dispersion about the mean, so we can integrate the inequalities conversation with this performance conversation, and also just ask ourselves, what can we systematically learn from the top decile performance, and you know, are we on the bottom decile, and is it moving? Are they consistently staying the same? Just on the primary care access figure that you mentioned, it's on page 73. It's a really interesting progress from like 60% in August 24 to 74% now, and having plateaued for a while, it's now seemingly trending up. I just want to know what had driven that, and how high can we go? You know, what are the top performers doing? But also, is that showing any impact in terms of reduced pressure on hospital admissions, etc., A&E, or is there no correlation between this improvement and pressure on the system elsewhere? Okay, let's keep going round, but come back on some of that. Louise?
Yes, so thank you, David. And I found the slides and the data really easy to digest, so thank you very much to the team for that. Building on Penny's point about healthy life expectancy, in the population health section, I was sort of looking for a sort of underlying population outcomes framework, which we're asking ICBs to commission on the basis of, do we have an understanding nationally of where we want health to be, effectively? So, and then I had questions about nearly every slide, but I'm sure happy to chat. Your point about deep dives is really good. I mean, things like cervical cancer, where are we on self-testing? You know, almost every slide. But where I thought there were omissions on experience, I thought the maternity slide on experience was really good, actually. But then there are lots of areas of experience that aren't here, about smoothness, efficient referrals, about experience with the complaint system, about being supported whilst waiting, about accessible information. So I wonder if the Quality Committee could potentially start to think about other metrics of experience that could be included in that section.
Excellent.
So keep going around and collect questions, but I think on that point, Louise, if I want to go into a lot of it, what we need to do is think through which bits do we cover at which subcommittees, and how do we quite systematically make sure that we bring some of those deep dives, as it were, areas of focus to the board meetings over a year, because we won't be able to cover everything. Duncan?
Yeah, thanks, Penny. I guess just a couple of points. One being about children, and just recognising about 24% of our population are children. How we look at this through the lens of the needs of children across our different measures. So I guess an ask on that. On maternity, I think absolutely right. We're doing some work with trusts at the moment, looking at what measures we're expecting boards to look at for maternity. So I think it's really important that we mirror that here, so we could perhaps bring that back at a future deep dive. And then I guess with the shift from hospital to community, just really thinking through, have we got enough visibility on some of our quality measures within community services? So for example, leg ulcer healing rates, under 12 weeks, for example, might be a good way of putting some visibility on that, and links into some of the conversations we're going to be having today about greener and cost savings, etc. As well. And then I know we've got the team talking about inequalities, but there is something about kind of how do we structure, and perhaps it's for the deep dives, a rhythm of looking at inequalities through multiple different lenses: ethnicity, women's health, men's health, for example.
So, and geographical.
Yeah.
Definition, absolutely. And I'd add to your list mental health as well. We don't have enough data. Okay, Andrew?
So just to echo the points around maternity, I think this board should see the maternity performance data by system at least once a quarter, given all of the kind of media coverage and interest that board members have had in this service. My main point was around 4 hours. So we're at a kind of pivot point in the sense that we'll be getting ready for preparation for winter, and we're slightly behind the curve at the moment. So what do you think the causes are in terms of the fact that we're not quite there in terms of meeting our trajectory, and going into the next 6 months, how can we help organisations deliver? I mean, it may be a separate topic area, but I think it's really important that we keep a tab on this, because every day there's 1 million people touch general practice, but there's also a big slice of our local national population that go into the emergency departments. And normally at this time of year we do have that conversation around prep for the next 6 months.
Okay, so because I think we may have some more questions, just to make this a bit manageable, I think all the question about where we know we need more data and better data and how we do deep dive, let's take that offline and we'll come back and manage that. I think 2 specifics, if you could focus on or ask a friend: primary care access, why has it got better, and how do we continue that? Has it really got better, maybe as well, and how do we continue that trajectory? And then 4-hour performance, and then I'll take more questions.
Thanks very much, Penny. So I will ask a friend on the first one. Really? And that friend is Claire.
Thanks very much. So, Ravi, thank you for the question. The reason why GP access has improved so much is that we had a plan and we've delivered the plan, would be the short answer. So 3 things. So 1, we invested in cloud-based telephony. So we've moved practically all of our GP surgeries over onto cloud-based telephony, which means then we can, if people phone, we can then call them back. We know how many people are waiting. We've got better data to look at around call answering times. Number 2, we've changed the operating model. So for people that have been struggling with access, they've been supported through the GP improvement plan in moving over to modern general practice, which is about how you deal with all the calls coming in and you triage to identify greater need on the day so you can see the people that need to be seen. And then thirdly, it's the use of technology. So we've increased the amount of online access, but also the use of the app. So the increase in the number of people that are accessing and ordering their repeat prescriptions via the app takes a lot of traffic out of calls coming to general practice. And then on your second point about has this made any difference, what we've found from the PCN test site pilots is actually for those practices that have got their access under control, and by access under control I mean that they're answering their call within 1 or within 2 minutes consistently across the day, including at 8 a.m, and that they can offer on the day appointments of those people that need it. When they've done that, they then have got the headspace and the capacity to start to properly deal with the proactive care and start to look after their complex patients and start to look after and increase their management of long-term conditions. And where they've done that, you can start to see the impact. Our problem is, and we'll talk about this afternoon, but our problem is that we've got that in small pockets, and what we've got to do is scale it.
Thank you. And The PCN work is primary care networks.
Sorry, thank you, Penny.
Where Claire and colleagues have been working with a number of those that to look at what are they doing that's working well and where could that be learnt from and taken more widely. 4 hours.
Yeah, thanks, Andrew. So I think just to break it into the two parts, we've got the what can we do to try and make a step change improvement in 4 hours, and then we've got the link to what that tells us about winter preparation, given that we're now in mid-September. So I think on 4 hours, as you've just said, essentially, the word is stuck. So the performance is pretty consistent, but consistently not where it needs to be. The NHS's own trajectories were showing an improvement over the summer period, which essentially hasn't happened. So it does feel like we're in that place. In terms of things that we are doing about that now, there's some real stuff just around consistency. So we know that the departments that do well stream away from the front door into the UTCs. They use their UTC capacity consistently, and it's open, long and extended hours. So we've got a focused look at that. We've still got people with UTCs that are letting UTC type patients through into the emergency department. And then in terms of the pathways within, although we've had a lot of focus on admitted, again, we're quite stuck. We've done a big piece of work on what the first 72 hours of care should look like and the standards in terms of the clinical input into pathways, but the non-admitted group we know is also a big driver of the 4-hour performance, and there we've got real lack of consistency in terms of the way that people have developed services inside. So people who've got the way people are using their SDECs, their CDUs, the pathways, and the way things are
what
counted.
all those things are. UTCs, SDECs.
So once you go through an emergency department door and someone said, this is, it's not consistent at all. You wouldn't expect the consistent, obviously, to be laid out the same. Hospitals look different. But I think as a member of the public, you could reasonably expect that, the services there would be quite similar, that if you were in this kind of area, a same-day emergency care, you get this type of treatment, it's counted in that way, or if you're in a clinical decision unit, it's this part of treatment that gets counted that way. It is all. So what we're trying to do is just bring back some of those data definitions, standards and methods that we know work. The more departments we go and look close up to, the more exactly the same care is being counted very, very differently. So we need to get back into all of these. I'm going to call them basics, but we know the basics things are often hard. And then just to complete the picture, some of it's technical, but some of it's hearts and minds, I think, because there's so much complexity. Jim said the departments are overcrowded, big focus on corridor care. I think there's a sense that it's become impossible. And actually, it isn't if we get back to some of those basic things that we know work. So there's a bit of a technical and a bit of a hearts and minds bit. In terms of prep for winter, that's also continuing at a huge pace. So since we last met at a board, all the regions have come together and we've had these EPRR-style exercises, planning against 3 scenarios. People have taken their learning away in terms of what they need to do to tighten up plans. So there's no doubt it's going to be a challenging period, but I think the preparation that we've done this year has been more extensive, not just in terms of what people are going to do, but how they're going to respond under pressure, what triggers they're looking for, how they step up and coordinate across. So, two activities that are connected, but I think, as Jim said at the beginning, really, we just need to complement how the leadership have stepped up, particularly on the winter preparation, because I think we've seen quite a different level of planning and planned response so far.
Okay, so more questions. So I've got Jeremy, I've got Meghana. Let's take those two.
Just a quick thought, really, David, for the pack. I think it's great, but it does risk becoming infinite. And just a thought from the retail world as whether we could digitise it and make it interactive and have various lenses on it, so that rather than trying to print out everything, if you're wanting to drill into maternity or to look at various performances, you just click on the link and work it through, put it on an app, and be much more accessible. So just a thought.
And a bit more red, amber, green.
Yeah.
Meghana?
Just wanted to add to what Sarah Jane was saying in terms of urgent emergency care. Clinical leadership obviously is vital. So in addition to collaborating collaborating well with care before coming into accident emergency or emergency departments. It's the internal processes that matter as well. So there are tools like the iRefer tool for radiology to reduce unnecessary diagnostics. I think that is being used and needs to be used even more. Specialist opinion, trying to get specialists and the first 72 hours of care within hospitals is again crucial so that people are seen and taken to their right destination for the right care in appropriate time. And then lastly, again, coming back to tech. So for discharge, to stop the delays and the pharmacy take-home drugs, etc., all of those things have to be implemented consistently across all the organizations to sort of make sure that the discharge process isn't held up. And a focus on all of this, led clinically, is something that we are definitely doing.
Okay. So I think let's come back to probably the next board meeting is, because otherwise it feels like a bit the same conversation every year. What does our medium-term UEC strategy look like? I know you've been doing a lot of work on that. Robert?
Just a very quick one in winter prep. Just an update on the vaccination, how good the vaccine uptake has been for flu and COVID.
We can bring that. I mean, for most organisations, including my own, that starts on October 1st, but we'll make sure we bring the details.
The paediatric and the maternity campaigns have been launched, but the general population campaign starts on the 1st of October. So, but yeah, I think it is well powered up, and the actions that we committed to, each of those have been ticked off, Robert. So the ability to be able to book appointments and all those kind of things, we've really taken the learning from last year on those. So we'll start to feed the figures through on a weekly basis from the beginning of October.
Okay, last comment from Rob and then go on to finance.
And just linked onto that vaccination, there's been a huge response and energy from the service in terms of staff vaccinations. Had a couple of sessions with 250 attendees on each from comms and the clinical community, so I think there's a real energy to try to do even better than even better than what's set out in the UEC strategy in terms of and if we can get it right for staff, that's going to help us, I think, in terms of getting it right for patients as well.
Right, thank you. Elizabeth?
Yeah, thank you. So moving on to the money then, and a financial performance update. It's at quite a high level, but currently the paper covers both revenue and capital. It highlights the main risks as we move forward and some of the forward actions, and I think David and I will also cover what we intend to do during the mid-year review. But first and foremost, I'd just like to thank the service, actually, because the level of grip that we've seen that people have is actually continues to show up in the numbers. So the NHS at month 4 is broadly on plan. We are currently reporting a £57 million overspend in aggregate, which is about 0.1% of the year-to-date allocation, which is a significant improvement on this time last year, which was close to 500 million. Key drivers, the pressure points that I talked about last month, they remain unchanged. So we're seeing missed efficiency targets and rising workforce and pay costs. Also in the month 4 numbers will be some of the costs of the 5 days of industrial action that took place in July. We know this has had a measurable impact, but many providers have reported back to us that they've covered these increased costs in their plans. And we have ensured that there are 2 systems which haven't received their deficit support funding as at month 4, but that deficit support funding is included in the aggregate numbers. You'll also see from the report there are 6 systems that account for half of the overall overspend, and 16 systems and 44% of providers are currently on plan, and the full detail is within the pack. We continue to forecast that at the end of this financial year we will deliver the plan that was signed off earlier in the year by all of the boards out there in the systems. We are making sure that the cash flows appropriately to keep the business running. We have tightened the cash rules, but we are being very pragmatic and working through that very closely with individual CFOs and boards. Having said this, and at the leadership event we talked about this, we do know the plans are backloaded. not to the degree that it has been in previous years, but even so. And therefore, we're asking people to be very, very focused for the residual months of this year and into the second half of the year. This midpoint is going to be absolutely crucial. So the conversations we're having are around boards needing to be clear and not take comfort from year-to-date variances, to really look at run rate spend and what's driving their financial performance. And we've also signalled at the event that we are going to do a mid-year review process that we'll talk about shortly. And that is very much focused on not looking back, but making sure that boards have got credible plans to deliver, not just on finance, but across the board for the remainder of this year. We have talked quite extensively to the CFO communities that are signalling, how challenges looking for the remainder of the year, about risks and the opportunity to mitigate some of those through detailed recovery plans, and some of those recovery plans are in motion. And also at month 6, we have signalled that we're going to do something called a true-up exercise. Now, this is mainly because we have got a scenario where anecdotally we were hearing that people were stopping some of their elective recovery because of finance. So we've gone back to have a look at the reality of that, and what we're actually seeing is a very mixed picture. So we're seeing that some providers absolutely seem to be constraining activity as a consequence of finance, and there we're going back to make sure ICBs have commissioned the appropriate level of activity to deliver the standards. Conversely, we're also seeing that some providers have actually earned income in 12ths and they haven't delivered the activity. So this month 6 exercise is going to be really important, because as we think about what the recovery is for the remainder of the year, we need to know the issue we're actually tackling. And we need a lot of transparency on this, so that's going to be important. On capital, so we've spent about 13% of the full year budget on capital. That's not unusual, so it's 1.28 billion. And we're currently forecasting a £240 million underspend at the end of this year. Again, we're going to do a mid-year review. It's actually kicked off, where we're asking people to really look at their capital forecasting. The plans don't look as good as they should have been, and I think more focus was put on revenue. And as a consequence of this, if people come forward and say they're going to underspend on their capital and they do it early enough, we're going to look at how we actually broker this across the wider NHS so that people can carry forward any capital into next year. However, if this happens in the last quarter or towards the back end of the year in an unplanned way, then that is going to be a bit of a travesty, to be honest, because it's going to be too late for us to do anything, and capital is a hugely scarce resource. So no surprises we're asking for, and I keep asking wherever I go, please just keep talking to myself and the team around capital. And then on to just quickly emerging risks, I suppose, is the unfunded redundancy across ICBs and obviously national bodies. It's cost pressures in specialised commissioning, particularly high-cost devices. And I think I mentioned this in a previous board meeting, that we have got a scenario where there are cost-effective high-cost devices that providers and clinicians could use. Could use a more cost-effective device, but they are still choosing, even though that there's not a clinical reason to choose the higher cost one. So we're looking at how we reimburse on that. Even partway through the year, we may change our approach. And then the other material risk will be the further risk of industrial action. Within the paper as well, there is a update on VPAG and industrial engagement, Chair, where VPAG is Voluntary Scheme for Branded Medicines, Pricing, Access and Growth. So it's a bit of a mouthful, which is why we shorten it to VPAG. And really, just to conclude, I suppose, the NHS has engaged with pharma companies to look at and proactively engage about how we might look at working with the industry in a more responsive way. All of the proposals that have been put forward to date, the pharma companies have responded negatively to, including withdrawal of new drugs from the UK market. And as a consequence, we are where we are at the moment. We remain with our existing arrangements, and I'm sure we will wait to see what happens next.
Okay, thank you. Questions for Elizabeth? Andrew?
Can I just raise a point around the deficit support? The 2.2 billion that's gone in. Is that tapered, Elizabeth, for over a number of years, or is it a cliff edge that providers drop or systems drop at 31st of March?
Yeah, so it's annual, and in the 10-year health plan, we signalled that we would move away from the deficit support funding approach through the work that we've been doing with extensive engagement, actually over 600 people to date, around some of this, around the allocation formula. We are looking to actually put some of our deficit support funding into core allocations to move people closer to target. And the withdrawal of deficit support, how it's actually described in the 10-year health plan, which we're working through, is we will start to withdraw it from 26-27.
And if you're overspent, let's take an example, Lancs, they've got 164 mil of support, they're over by 20. So what happens at the year end if they've had that money and they're still over?
So
does the over commitment, does that get locked off the following year? Or is it just written off?
The sorry.
If the outturn is more than 164 deficit for that particular system, what happens to that lump of cash that they've exceeded?
Yeah. So if in an example a system actually does not deliver its plan, the deficit with the deficit support funding is withheld. At the end of the year, that could be reallocated. We'll make sure that there's cash to pay staff and bills. However, if a system goes off plan at the end of the year, that is carried forward effectively, and it goes into the historic debt reprofiling. So you don't get it written off. I think we need to be really clear that the deficit support funding will flow this year if people are on plan.
Okay, thank you.
I'll just follow up on that one and then take some wider questions. First off is, in that Annex 1, could we have a 1A and a 1B? So 1A shown as it is, but 1B ordering by deficit support, so we can see the sort of true costs. The second is, when we start getting systems coming back with their medium-term plans, will we be able to see, is this system overspent because they're spending money on either care which doesn't impact health, so they're not allocating money in the most impactful way, or because they are spending their unit cost, either provider costs are higher than they should be, i.e. they are paying for inefficient services. Will we be able to see where they are on that? I.e., is it allocative efficiency or is it technical efficiency that's their challenge?
Yeah, okay.
Do you think we will be able to see that when they come out?
I think we'll have. I'm thinking of the timing of some exercises.
Yeah.
So the bit about the efficient delivery of care you would usually see through reference cost indices, but that happens at a different time frame. We've got lots of points of data. They wouldn't all coincide with a medium-term plan. So I think we would look to triangulate that. What we will have, though, Penny, is we'll have the very detailed productivity plaques that we can overlay against the medium-term plan to see what the scale of the opportunity is at that point, and whether or not they're factoring that into the plan to address it.
Okay, thank you. So I've got Louise, I've got Robert, I've got David.
Thanks, Elizabeth. So how can we make sure that patient care isn't impacted if trade-offs are being made by systems in order to reach their efficiency targets? You touched on it a bit with the electives.
Yep. Let me take all the questions and come back to that. Robert?
A comment and a question on the drug pricing challenge. I think this is a very, very menacing threat. It's had a lot of press coverage. So you refer to withdrawing drugs, but AstraZeneca pulling back on its investment in Cambridge and Merck pulling out completely of its building in King's Cross. One of the government's top priorities is growth. So I don't feel that the burden should appropriately fall entirely on the NHS. I mean, this is a national issue, but the NHS should lobby for its importance in terms of us being at the forefront of innovation. So my question, I suppose, is the steps that you're taking, which look absolutely terrific and appropriate. how reassuring can you be that this is registering and it's going to turn things around? I forgot to add that the problem is intensified, of course, by the Trump administration, which is bearing down on drug costs in the US, which have been bankrolling pharma until now. And so it's not surprising, but it's coming home to roost here.
David?
Just a small technical point to reinforce your point about making the tables more useful. Can we put a column in with these numbers as a percentage of turnover? Because it's difficult to judge how significant these numbers are without that.
Yeah. Okay, so quality versus cost, and then the pharma industry bit.
So absolutely. So Louise, on the quality, and cost dynamic. So all of the work that we're doing, we're consistently asking those questions and asking for quality impact assessments. We don't in finance, definitely not in this team, work in isolation of our clinical colleagues. So that is front and foremost. And also, as we're making the CIPs or productivity savings, we triangulate them with a number of quality indicators. So, if we're looking at some of our policy changes, we're looking at readmissions rates, we're looking at harm, we're looking at some of those mechanisms. And in some of the efficiency savings, we'll also have it's called waste, which I know that waste and harm. I think people don't like those terms in terms of the buckets, but we are constantly driving and making sure that the conversations that we're having are both with the finance community, but also our clinical colleagues. So I feel there's a lot of work that goes on there. I can definitely bring it out in the report going forward. Touching on something that Jeremy described, we've got so much information. Maybe again, it's about enabling a drill down, because whichever way I present it, we could always present it a different way, and people will be looking at different things. And then just touching on the report and that David's described, we're trying to bring it to make it more holistic so that you can look across a range of indicators to see that triangulation yourselves.
Okay. One thing it would be great for us to get to, and I recognise it's not easy, but it's a bit linked to what I said before, is we should be looking to say to what degree are we allocating money to maximise the health of the population, which is our ultimate remit, is to do that. So we ought to be able to say, if we were really spending money in order to improve health outcomes, where do we think we would be spending the money? What would be the sorts of services we'd be spending the money on, and how close are we to that in each ICB? There's a sort of, we don't have that yet, but we ought to be able to do that. And then the second bit, which I know you are working on, is to say, how do we define from the national service frameworks, the modern service frameworks, the care pathway design, what does really high quality care look like? And crucially, what should that cost? Because we think that it probably should cost less than what we're spending now, because we have big productivity opportunities in there. But if we could define that, I think, more clearly and demonstrate that should give assurance that driving on improved productivity and getting the money to work better is actually focusing on improving quality, not distracting from it.
Yeah, absolutely.
So do you want to talk about the pharma industry piece?
So I think in the report we highlight the way that NHS England's actually continuing to engage with the industry and trying to be incredibly proactive. But as you've described, I think the scale of the risk, it's bigger than just for the NHS. I think I get a sense we are absolutely being heard in terms of our conversations, both through with colleagues at the Department of Health and through to Treasury. I'm not sure there's much more I can say at this stage, if I'm honest, but the conversations are live, and I guess what we should do as NHS England at the moment is continue to build those relationships, invest in the things that only we can do, and I think that some of the wider decisions around macro investment have to happen those decisions have to happen elsewhere.
Okay, thank you. Right, so we've gone through performance. We're now saying what are we going to do about it. Jim, 10-year plan? I think to pick up Paul's point from earlier, the risks of us not reforming and adapting.
Absolutely. So as we discussed earlier on, the 10-year plan was published, landed very well, lots of enthusiasm in the service. We have tried very hard to resist issuing a big delivery plan with lots of instructions in. We've worked with colleagues in the service around a bunch of work streams that are all about bringing the plan to life. We're now in a process of refining those, mainly around impact, to make sure we know that these things have a purpose in the end and there's a quantifiable purpose. I would expect that to be complete in the next week or so. And then we're trying to dovetail this into the medium-term plan process, which we're still aiming to get out into the service end of September, early October. There's an awful lot to be done to be able to do that. The key part of all that, as you said, Penny, is to try to get the balance right between short-term imperatives and long-term, but also the extent to which these long-term changes actually address our short-term problems. And we're trying very hard with colleagues to just keep that balance right and get the prioritisation appropriate and the sequencing appropriate in terms of what happens next year and in subsequent years. So I think we're in very good shape. I think there is if we're honest, there is a tension with this thing about not giving lots of instruction, where I think that's generally welcomed, but every now and again you can have a conversation that says, I really don't want lots of instruction, but can you tell us what to do? And we just have to live with that. We're in a transition phase. It's a difficult process that we're in, but I think really fantastic progress so far.
Okay, good, and look forward to seeing more of those subsequent pieces evolving. Okay, great. So let's move on to a conversation about healthcare inequalities, or rather the Healthcare Inequalities Improvement Programme. Diane Habib, over to you. Assume the paper has been read, but if you want to just say a couple of points in summary, it'd be good, and then we'll open it up for questions.
Thank you very much. I took over from Professor Bola Owolabi a month ago and have been working with the programme to move it forward for the future, for the work set for the future. As Penny has said, I take the paper as being read, and I thought I would just highlight two specific examples of impact that we've delivered over the last year. So if you take the elective reform, and it's been very helpful hearing about the progress with the performance as David outlined. He talked about electives in terms of the granular data that has been published. And I think in the discussion, we talked about the average hiding the detail between what is really going on, who is doing well and who is not doing well. And one thing we've pushed with the elective reform program, we've worked very collaboratively with them, and we outlined a healthcare inequalities improvement ask. And you would see that in July, the data was published, granular data was published, disaggregated by age, by sex, by deprivation, and by ethnicity. And that highlighted where the challenges were, which groups had challenges, and what differences it could be made by addressing those challenges. So we see, for example, that people in deprived populations are waiting much longer. We see, for example, women are waiting much longer. We see, for example, that people in working ages are waiting much longer. This had previously not happened, and it's, with the work that we've done, that has been highlighted, and we're now working with systems to say, we've highlighted the problem, what are you doing about it? These are some of the things you can do about it. The second point I wanted to highlight as a success has been that with executive support, we actually started supporting systems deliver a quality improvement program with sickle cell. We had significant challenges with ECUs. The main reason a patient with sickle cell will go to the emergency room is for an uncomplicated crisis. They utilize the emergency room, high-intensity users. What we've done is we have over the year delivered 7 emergency department bypass units. I visited Lewisham last week. They have, for the very first time since NICE published its guidance in 2012 about achieving a 30-minute target when patients come to emergency, have for the very first time delivered pain relief 97% of the time. Hasn't previously happened. Spoke to patients, engaged with patients, has made a significant improvement in their experience. Spending less time in hospital, has decreased admission time, has improved patient experience. Patients are going home much earlier, improved productivity. They were not utilizing clinicians. They have proposed a different model where they've used advanced clinical practitioners. So it hasn't been so much of a challenge to get people in. Moving forward, we have proposed in our report, you would see, to pivot our work program to enable delivery of the 10-year plan. We are also rephrasing our narrative so that it takes on board the challenges the system currently faces and the priorities that are going to be delivered by the system. We will be focusing on working with various teams, the finance team, to address resource allocation so that it is balanced. And as Penny said, it addresses the issue of how will we allocate finances if we want to improve outcomes and care and reduce healthcare inequalities. We'll be doing that work with the finance team, and we've prioritized that. We'll be working with the system development team to hardwire addressing inequalities through all the work we are doing. If we are not going to be asking the system explicitly every year in planning guidance that this is what you should be delivering, then it's got to be in the system so that they know that this is what we should be doing and this is what good looks like if we are addressing what health inequalities are. So we'll be working with the system development team to ensure that happens. Whether it's about strategic commissioning, whether it's about developing integrated health organizations, or whether it's a foundation trust contract. So we'll be doing that. We'll also be working with, and David doesn't know this yet, but we'll be working with you to ensure.
I'm a bit concerned. We want to have time for questions.
Sorry.
So
Okay.
You've set out here your 6 priorities, so I think we've got that. We understand, and we'll come on and ask some questions about that.
Underlying all this will have to be data, and so I'll be working with Ming on that to ensure the granularity of the data feeds through all this.
Okay.
I'll pass on to Habib.
I'll be very quick. The Observatory continues to be a delivery partner for the NHS England and for the Department of Health and Social Care. Our role is not just to highlight the scale of the challenge, but to provide solutions. And on that basis, I'll highlight 3 quick examples. Firstly, bringing together evidence and insight, our partnership with the National Institute for Health and Care Research to build in equity and inclusion within the criteria for commissioning research is ongoing and progressing. We are bringing together secondly, in terms of driving policy change, we are bringing together all of the healthcare regulatory bodies to work from the same page when it comes to equity and inclusion in terms of accountability, which is a key lever in terms of shifting the dial on inequality. We have a groundbreaking partnership with NICE, the National Institute for Health and Care Excellence, to de-bias current clinical guidelines across a range of areas, and also working with them to build processes within NICE so that the development of any new guidelines do not have those biases built in from the outset. And thirdly, in terms of implementation support, we're working with 8 ICSs to look at closing down the maternity mortality gap by ethnicity and looking at neonatal testing as well. And in collaboration with Duncan and the team, we rolled out mannequins and birthing stimulators in different skin tones for the first time in the history of the NHS across every maternity unit in the country, and working on mental health, Gypsy Roman Traveller mental health as well. Looking ahead very quickly, we're engaging with the 10-year plan team and the neighbourhood health services team to look at building levels of trust and confidence in healthcare services more generally. And of course, finally, if we're in the business of tackling health inequalities, which we are, then we need a workforce that's fully supported and engaged at all levels. So we're focusing on looking at the independent ethnicity pay and progression gap across the NHS workforce, and secondly, looking at closing down the gap in terms of bullying and harassment by ethnicity, but also decreasing the overall levels of bullying and harassment across the whole of the workforce as well.
Great, thank you. Okay, so questions. I've got Duncan, Louise and Sam.
Yeah, thanks. I guess just a couple of points. One, the first being about, are we doing enough to integrate into the broader strategies that we've got under development at the moment? And we reflected the other day, Diane, obviously there's a piece of work we're looking at the LGBT health evidence at the moment, and we make sure that permeates through all the other strategies so it doesn't sit in isolation. So just any reflections on, are we doing enough in that space? And then the Race and Health Observatory's got a really respected brand associated with it. It's doing a phenomenal amount of work, and I'm just wondering whether we are doing enough to leverage the impact across the NHS with all of the parts of that. And I just welcome some reflections on that.
Okay, I'm going to take all the questions first. Louise? Yeah.
So, yeah, thank you, Habib and Dan, for your fantastic work, and your reports were great. So, two questions. The first is, in your view, how should funding flows change to reduce inequalities in health? And the second is about racism, of which we've seen some manifestation in public recently. What do you think the NHS's role is in helping to reduce racism, because we know it has a significant impact on health?
Okay, Sam?
Yeah, Penny rightly pointed out in the performance report, page 7, which is really worrying, and a drop in healthy life expectancy. And in my community, it's even worse. In some ethnic groups, women are living shorter lives and more unhealthy lives than men, which is why we got free swimming given by our mayor for all women over the age of 16. My question, though, is actually, have you got the data that breaks this down into ethnicity in terms of healthy life expectancy that we see on page 7? And secondly, in terms of socioeconomic groups, so that we know the expectation by 2040 is that healthy life expectancy will be 20 years difference between rich and poor. So if you live in a poor area, you will expect to hit chronic disease by the age of 50. So have we got this sort of breakdown of data? And finally, I think all of this data is beginning to show us very clearly the moral cost of not dealing with inequalities, but we know what the cost is to the NHS of not dealing with these various inequalities.
Okay, were you going to ask a question, Sarah? I don't know. Okay, so just to make sure we try and tackle these, I think we've got a key thing from Duncan on how do we make sure we weave an inequalities lens into all of our ongoing work, maybe focus on that. I think the question on funding strategies, Louise's question, I see that as baked into priority 4. But there's a question on all of these 6 priorities about what are the metrics, how are we going to know whether we're making a difference, and what are we going to look at, which then links into Sam's question about have we got more data that allows us to scrutinise in terms of actually probably all the performance data we looked at, how does it vary by geography, by sex, by racial groups and so on, a whole load more of that. So there's quite a bit on that, all related to data and how do we make this more comprehensive. And then we had quite specific questions on Louise's question about how we're thinking about racism. Was that in services or in society, or both?
Well, what's the role of the NHS to support health when racism exists in society? Because racism impacts on health of people of colour.
Okay. In a way that hasn't been picked up by what's already been shared in terms of what we're doing.
If people want to say more about it, I'd be grateful.
Okay. Does that cover? I think let's try and tackle those, otherwise we'll run out of time.
So in terms of integrating health inequalities in all that we do, I am meeting with all the directors and working with them to ensure that we are sighted on the work that they are doing, that we can input into what good looks like for reducing inequalities. So that's an ongoing piece of work, and I've met with actually several of the directors who are owning some of the programs. I've met with them already, and we've started ensuring that will happen going forward for those who've missed us out. In terms of the issue to do with what the funding flow looks like, I think it would be exceptionally important to include deprivation, explicitly include deprivation. When you look at the data on what is driving inequalities, deprivation is a significant factor, and that needs to be included in a way that that hasn't previously happened, and that needs to be data driven. The last point I was making was about data. If we cannot measure it, if it is not being highlighted, then it is not surfaced for leaders to take action on. If we want to build a coalition of people who are determined to drive down inequalities, they need to have granular data. And that is going to be the focus of our discussion, Ming. And I spoke to your team with David Ashley yesterday. If we don't have the data broken down, granular, bringing together community, primary care, secondary care, and looking at the whole care pathway, we cannot drive improvements. We cannot drive improvements when we are looking at performance. We need the data. It's not negotiable.
Okay.
The point on racism.
Pick up, Lisa. Yeah.
Yeah, sure. So the NHS is a microcosm of wider society. 1.3 million people work in the NHS. What happens in the wider world is bound to be reflected within our workplaces. The NHS has a role to play, but it cannot be the only enabler for equity, and we know that. But the role that it is playing includes setting up the NHS Race and Health Observatory, if I may say that, and the work that we're doing in terms of looking at maternal health, looking at how we can apply an anti-racism approach to QI methodology, which is a method that's used a lot across the whole of the NHS. And then going back to the point around the cost of racism, I think, which was also raised, I think that's an important point, because we need to know the impact that racism has, both in terms of the human cost, but also the productivity and financial cost as well. And that's a piece of work that we are commissioning later this month to really kind of focus on and to provide even more evidence to help kind of focus on the solutions to the long-standing challenges that we have, not just in the NHS, but of course across the whole of society.
Thank you. Okay, really good conversation. Thank you, Diane, for taking up this work, and thank you, Habib, for joining us, and we'll make sure we come back to it. I think we have a risk that coming out of this morning, Ming has even more work to do. But we'll keep going. Right, Learning Disability and Autism Programme. Who's presenting on this? Tom.
Hi, good morning. Good morning, everyone. Tom Cahill, National Director for Learning Disability and Autism, former Chief Exec, not practising anymore. Just want to bring you up to speed on learning disability. You'll have the paper, so I won't go through the paper in detail. But we've just finished talking about inequalities. If you learn a disability, the chances are you won't make 50. If you learn disability with a profound learning disability and you're from an ethnic background, you won't make 34, 35, 36. So have a look around the room and how many people would make that life. So just I want to bring that home, that this is about people and we can do something. Learning disability programme came out of a failure, Winterbourne. Goes back, I'm sharing this with the board because I know a lot of you might be new to this. And back in 2015, really, really difficult circumstances, people treated very poorly. Over 2017, 2019 became part of the long-term plan. Government strategy around building right support for, one, getting people out of hospital, but two, helping people live longer, healthier lives. And that was the BTRS. Despite the narrative of failure, I've been doing this for 4 years. If you go around the country, there's some fantastic care and support. whether it's through key workers, whether people at acute hospitals are doing, seeing people at home before they come in for an operation. There's really good stuff, and we need to build that. Far more good stuff than there is of failures, but we do hear the failures, and when we do, they are loud. Programme is established in 2019, particularly I talked about, and there's two distinct groups just to share with you. So we've got people with learning disability, and some of them are autistic, about 30%. And then you've got a group of people who are autistic only. I'll just deal with those very, very briefly. In terms of learning disability, we had two real targets or work to do. So getting people out of hospital, particularly those who shouldn't be in hospital, not everybody. And we'd done some work about 2.5 years ago, and about 40% we knew that should not be in hospital. We're not convinced that 60% that should be there were getting the right care either, but we need to work in that. And we have broadly achieved that for learning disability, not for autistic people. I'll come to that in a second. The second part, we're focusing on health outcomes around annual health checks, 80% target and achieved. But there's 1.3 million people, there's only about 330 on GP registers. So you can see that there's still a big gap. And that 1.3 million, there's more we can do. If you see on the leader report, the median age of death is improved about a year over a 7-year period, 8-year period. So really positive. And the avoidable deaths are reduced from 47% to 38%. And these are really important because these are things we can do. And if you think about where we want to go next, we can target that. You've then got autistic people, and autistic people only. They have a propensity to experience mental health more than the normal population. Suicidal ideation, a significant risk. And what we are seeing is autistic people, young and old, coming into hospital, coming into mental health beds particularly, not into all learning disability beds as we might have formerly known them. And that's a significant increase. So we've been working over the last year to try and reduce that, make sure that the pathways are in place, working with mental health teams particularly to make sure that they're autism friendly. And you can see there on paragraph 12, it tells you the sort of work this autism team has been doing across the system. Also a lot of research, a lot of areas of good practice, whether it's in Manchester and Stockport with Johnson Greening's work, whether it's Nelft in London, North London, what they're doing around the neurodiversity pathways, some significant work there, and we're seeing progress. But equally, autistic people have the same life impacts as well about health outcomes, so we've got to continue to do that. So aligning ourselves with the 10-year plan, real opportunity for us and for this group. Neighbourhoods, you really get basic and get into the local population and to start making a difference and start putting things in place. And because of Leader, we've been doing it for 8 years, we know what we need to do. And I'll say a little bit about that in a second. Digital transformation, huge opportunity. I'll hear colleagues shouting at me, don't forget to tell them about the risks because not everyone can accessible, but that is something we can work with, and Ming, we have people who got 11 colleagues on our team who could be testing for you, who've got lived experience, so happy to do that. And clearly prevention programs and workforce planning and training, and when we talk about training, you might be talking about the Oliver McGowan training, and making sure, because we know that changes people's perspectives. It changes people's perspectives about people who are seen in A&E or wherever. So finally, from me, Chair, this is doable. This is not beyond the NHS, particularly on the NHS term. We know there's education, we know there's social care. You know, if we do the training for staff, if we do the reasonable adjustments that people need to get the right care at the right time, we have a digital flag, which is for disability, but is a game changer. And if we can use that, make sure that we use it properly on both ends. It's completed, and people then, when people turn up for clinics, hospital appointments, people understand what the reasonable adjustments are. Vaccinations, particularly flu. COVID is less of a concern now. Flu and respiratory is a big issue for us. Clinical pathways, respiratory, cancer, CVD, diabetes, obesity, the things that we know. And if systems and ICBs together put these in place, we can make that difference. And clearly, annual health checks for everybody. That's what we really need to get. And we're talking about mental health, people SMI, we're talking about learning disability, and we're talking about autism, combined health checks, and we're quite excited about that. So it's a quick canter through, Chair, of the paper, but the challenge, I think, we can make a difference here.
Thank you, Tom. Very good. Good example of what gets measured gets done. Okay, any questions for Tom? Andrew, yeah.
Tom, can I just ask a point around the voluntary sector? So where do you see the voluntary sector impacting on some of the measures that you've outlined?
Where we work very closely with the voluntary sector at the moment, and they, we call them our stakeholders, they do a lot of support that's probably not on the health side, but getting people to GPs, promoting annual health checks, but working alongside is much more on the social side of this. That's where I see that.
Okay, thank you.
Louise?
So, thank you. So, look forward to seeing a kind of, or the board discussing a fuller neurodevelopmental pathway piece, incorporating the really good work of the ADHD task force.
Yeah.
I've got a question about the table C and the waiting times. And it says, referrals open at least 13 weeks has seen a significant increase year on year. What's the range? So at least 13 weeks. What's the kind of higher level of the range? And how are people being supported whilst they wait?
Chair, honestly, I'm not able to give you the range here. Our support, we're certainly doing a lot with teams on supporting people in maintaining well while in the pathways. Doing a lot of work with ADHD task force about how can we reduce those on the pathways, but supporting families, supporting people, reaching out. There are some significant waits, and it is something we've got to deal with. I don't think, if we're honest, we can deal with it without additional funding, but actually we can't just stand still either, and that's part of the 8-point plan that we're working with Minister Kinnock and colleagues.
Yeah. Key bit we need to come back to. So
I would have thought so.
Yeah.
There is a good news story in there from, and I'm sorry I didn't share it. The ICBs have been really working well, and you can see for 2 months we've levelled off in terms of the increase and the closures. They've narrowed that gap. So, and that's without additional resources from the centre. So it's really good stuff. We need to support that and build on it.
Yeah, there's a lot more we need to do. Claire, and then I'm going to move us on.
Thank you. So, thank you, Tom. Really good, very clear paper. It was just a little bit more about the reasonable adjustments, because I think people sort of go into a little bit of a blind panic when they sort of think about reasonable adjustments. But actually, I mean, and so I have an autistic child, so I'm very familiar with the needs. And actually, what we should think about is, rather than designing environments that work for autistic people, actually just in designing environments. If you think about the things, the reasonable adjustments that most people would need, it's don't suddenly change my appointment at the last minute. Don't suddenly send me to a different appointment, different room. Give me information in a way that I can understand it. Let me bring somebody with me, and make sure the environment is as calm as possible. So I don't think actually we should focus on reasonable adjustments. We should talk about actually how we design services in a way that works for people.
So we have done quite a bit, and particularly the autism team, about what new services should look like and how they're designed. So inpatient areas, flooring, noise, all of those sensory issues, lighting, all of those things are really helpful. I think, Claire, it's where we've got existing facilities. How do we work for those? But it isn't just, as you said, it's not just environment. It's about how do we treat people.
Okay, great. Right, we're going to move us on. So, management and leadership development. Joe, Carolyn. I assume it's been read.
Yes, I will. I'll be really quick, thank you. Just 2 things. So thank you. We're seeking the board's review and approval of the management leadership framework today, which basically for the first time means that there'll be a clear set of consistent standards and expectations of managing leaders at all levels, from entry level right to board level, which, incredibly we've never had before. So we are at the start of a very long overdue journey. The reason why we've got where we are is not thanks to me, thanks to people like like Carolyn May and the team who've done work with thousands of people across the system, working with the Chartered Management Institute and lots of people that Caroline can tell you about to get to where we've got today. So as I say, it is the beginning of a journey. It's not perfect, I will say that. I think there were many sort of refines in the language. As the 10-year plan evolves, I think our notion of what management and leadership is required will change, and we need to keep that under constant review. It's a foundation that we can start to build on and develop from there. And then secondly, if the board approves that, then in the light of that, we need to align the standards with the board competency framework. And so we're recommending in 26 and 27, we use this new leadership framework for board level managers and leaders. So take questions.
Okay, let's take questions. So David, Paul and Robert and Ming. Okay, take all those. We'll take all the questions together. So David.
I welcome this approach. I would make 3 points. One, hopefully it has both developmental and assessment aspects to it, performance assessment. On assessment, I would observe that to do this sort of thing well, it's very resource intensive. So, for example, if you are evaluating the performance of someone, ideally that is not just done by their line manager, where all sorts of issues arise. The moment you have a group of people assessing individuals, then it starts to get very resource intensive. Secondly, on assessment, and then finally on development, we know that the best way to learn is on the job by observing other people who do things well. And so coaching, I think, needs a lot of emphasis in terms of the performance indicators for line managers all the way up the chain.
Okay, let's keep going round because we might find we've got some common themes. Paul?
And linking to David's point about how to make this improvement happen, 85% of people had appraisal, and 26% said it improved their job. Mm-hmm. So appraisal doesn't appraise very well at the moment, and therefore, given that by April next year we're going to be wanting managers to manage a great deal of change, the nature of appraisal from then will have to be quite a lot better. And so therefore the developmental programme to develop appraisal by next April better get going quite quickly. Otherwise, and in a sense coming back to my very first point in this board about change, we lose a year. So given we're going to need managers to be managing difficult things, the appraisal of those managers needs to get going. And as David said, it is resource intensive, but the loss of resource of having only 26% of people improving their performance is gigantic.
Robert?
I mean, this is just so mission critical. It's crucial, and I think you're doing a great job. My question really is around the college that's being established, whether appropriate use is being made of skills from outside the NHS, from other sectors, and also whether business schools in universities, some of which are very motivated to engage with this, I know the one at King's is, for example, whether that is being drawn in to help.
Okay, and then Ming.
Thanks, Penny. Joe, I just wanted to link the last two conversations, so around learning disabilities, because I kind of chaired the neurodiversity network, and quite often a lot of the conditions that we create at work are not great, and line managers haven't been given that support. So I just wanted to make sure in any new programme that we do consider those kind of environmental things as well.
Okay, And Andrew was whispering in my ear whether this applies to NHS England as well as providers.
So I think every employer should guarantee an appraisal. Yes. We should be saying every year you should have a conversation with your boss. We have failed to do that in NHS England comprehensively, unfortunately. So if we're implementing this, we should apply it to our own organisation.
Going for it at the moment, Andrew, every minute of every day.
Okay, I'm going to have Mark and Glenn, and then I'll add a few things. Then we come back to you, Joe and Carolyn, including what do we do next, which I recognise.
So this is great thinking. Having just been through a 5-year journey of something like this, embedding is always the almost impossible task, and the reflection I have if I look past is we started off with something this long, literally this long, and we ended up with 8 words, and this is impossible to implement. So the thinking is amazing. I think the next task is how you synthesize it down into something that's repeatably consumable by people at every single level. And it's the sort of Winston Churchill quote, if I had more time, I'd write you a shorter letter. I think you probably need a shorter letter.
Glenn?
Yeah, I agree with Mark's comment on that, but I think it is a great framework. I think it concentrates on how we develop people that we have. I wonder whether we need to look more at values-based recruitment to ensure that we have people that we can more easily develop.
Yeah, good point. Okay. Well, I've got a few just to add as well, which I think very much build on what other people have said. So I have to say, I was very much where David and Paul was. It felt to me like this needs an evaluation framework. So I think it's great, the starting point, the stage 1, stage 2, stage 3, stage 4, but that almost says this is what we think you need. It doesn't say this is what acceptable performance would look like, this is what good performance, this is what very good, and this is what exceptional performance would look like. And I think we need that for all of these bits. That would make it longer, but that would almost be the implementation piece to support colleagues across the system. So if we're going to do it, it would need something that embeds that. That then, if we did that well, ought to take the 20% up, because actually it ought to then give people, even looking at an evaluation framework tells you this is what really good looks like, and so it gives you a bit of something to aspire to, or a learning curve. It feels like we need a lot more on that. I think there is this crucial bit about the developmental bit that David raised and then Robert raised. So how are we bringing much more external expertise into this? You know, we know that we have some great management expertise in the NHS. We know that there's some skill sets that we are missing and lacking, and I think we don't quite bring enough of that into it. And then I have to say I had a bit of a personal problem with some of the language in here. So, you know, there's one on self-effectiveness, keep safe. What does that mean? Does that mean I walk slowly down the corridor, or... and we keep using that word. I wouldn't know what that meant. And we've got things in here like patient-centred care. I don't know what that means. We've got a whole lot of really good patient experience metrics which we could be aspiring to. So we've got a bit too much fuzzy language in here, and I think we need to be much clearer on the sorts of things we've been talking about today, like do we have a group of managers who can really think about resource allocation? We do refer to that, but I'm not sure it's quite tight enough. Are we really thinking about great user experience? What's that mean? Are we really thinking about this point Paul made at the beginning about the risks of not changing, sometimes greater than the risks of change? So I think it'd be good to hear your thoughts on how do we make this much more, how do we embed evaluation throughout this? How are we thinking about development that goes alongside this, including in external expertise? How can we tighten up some of the language? And then what do you want to do with this? So do we want to roll it out as it is, recognising some of the questions, concerns, or do you want to do a bit more work on it and then roll it out?
It's quite Quite a lot there, Penny. So just I'll come in on some of those, and then I'll ask you to come back on some of the specifics. Then I'll wrap up in terms of the next steps. But yeah, I completely agree with you, Glenn, about values-based recruitment. If we want to change the culture within our workforce, then actually it's the people that we recruit, and the people who join the NHS tend to be much more values-based anyway, and the younger generation even more so. So I think we need to reflect that in the 10-year workforce plan that we're developing. And absolutely, Mark and Penny, we need to. It's fantastic work, but I think it's been very much facing the people who've been developing it, and we need to flip it and make it, as you say, succinct and meaningful to those who are going to use it and talk about it, drawing on all of that great work. I think it is definitely meant to be developmental, and I might ask Karen to explain sort of how we're doing that and how we're involving other sectors in that.
Yeah, certainly. Thank you all very much for your questions. So absolutely, this is a developmental framework, and the intention is to launch with a self-assessment toolkit, and then a 360-degree feedback tool next year, picking up on David's point around feedback from other people, recognising it's resource intensive. Behind this then sits a national development curriculum linking to the code and standards, which will guide development in terms of the core competencies and expectations for leaders and managers at different levels. I think the key point is we've engaged hugely on this piece of work. So over 1,000 people have fed in. So of course, sometimes the language isn't exactly what everyone would want, and it's been a balance to try to get everyone kind of satisfied with the feedback that's been given. Just on the point about external guidance and development and learning from other sectors, as part of that national development curriculum, lots of that is featured there, and case studies and learning and how people can apply that learning in the NHS. Excuse me. The other thing I just wanted to pick up, Penny, with your point about what does good and not so good look like. That's exactly what we've actually developed for the Code of Practice in terms of what's really good behaviour and values, what does that look like, what's unacceptable, and the plan is to publish that alongside the framework so people know line managers know what good and not so good looks like. Just on the appraisal, really important. The very next step for us is working with a steering group to develop that appraisal core framework. But we also think training for line managers is going to be absolutely critical there, because this is a kind of cultural change about how to do appraisal really well in a motivational way. Apologies for my voice.
Can we just get over tonsillitis? Sorry, she's been really good to come in. But I think your point about timing, Penny, is really key. We were planning to launch this in autumn. So I think it's how quickly we can sort of take it offline and just address and finesse, particularly the language and the succinctness, without losing the pace. I'd like to think that we could still sort of crack on, but I think it'd be a problem if it went beyond autumn, wouldn't it, in terms of what we were trying to do.
Well, it delays because the intention is to ask people to self-assess against the framework as part of the next appraisal round. So obviously we need a kind of final version of the framework and final version of the appraisal framework for them to do that.
Okay, and Andrew's reminding me, which I was involved in, that when we had the chairs and the NEDS framework, it went down like a lead balloon.
So I think the trick is to take up Mark's point around making this succinct and giving some latitude for boards around, just doing it your way, because everyone will want to put their own kind of spin on this. So we're offering a way of doing this that's proven to work, but you may have situations where a board particularly wants it done in XYZ way. And I think we should give people that latitude. And last time round, this didn't go down well with some people. But I think if we try and make it succinct as possible, we hopefully will be a lot more successful, because there's some really good stuff in here.
Okay, so can I make a suggestion? Which one? Here we go. So it will still be autumn in November. So we've got
in the northeast now.
So we've got a couple of months. I think there's a lot of expertise around this table. So can I suggest we take views from around because we don't have time to do that now. We take views from around this table. You've heard some of them. We can come back and try and get people to do that. So I think we would ask everyone here to come back with their thoughts and comments quickly, like I might say by the end of September. And then the two of you have a chance to reflect on that. Perhaps bring it back for another shorter conversation with Jim and exec colleagues, taking on board the things that have been said, and then we make a decision about what to do with it during October, which would allow us to meet. Is that all right?
That sounds good. I was just thinking, if you look at slide 8 as an example, if this went out as it is, chief people officers and organisations generally will realign all of their appraisal documentation and the frameworks, and there's quite a lot of work involved in that. Some of them have just done it, some of them have been an established partner, being happy with it, etc. So on your point, Andrew, I don't know if you've done it, but just it's worth talking to some colleagues out there about what would take to actually bring this to life without everybody tearing everything up, starting again from scratch, and that actually then taking longer.
Just to come back on that, Jim, so we're engaging with over 130 organisations in terms of early adoption, and we're already doing that engagement piece about how do we implement this well and work with them with community to practice. So thank you.
Okay. So are you okay with what suggested in terms of next steps, Jim?
Yep.
Okay. All right. Good. Right, now on to covering an awful lot today. Greener NHS.
Thanks,
David.
Thanks, Chair. So I'll hand over to Chris in a moment, but just say a couple of very, very quick things. Firstly, I'm delighted that we've got this report in public board. This is part of the delivering the net zero strategy, and I suppose, as you'll see in the report, it presents good examples in two things. One, the moral obligation to get involved with this work, which the NHS has, and you'll hear from Chris, has done incredibly well. Secondly, and highlighted throughout the report, genuine cost savings and efficiency as a result of being involved in this. And then finally, and I can say this as a hospital chief executive, this stuff really matters to our staff. So there is a third benefit from the good work that Chris and his colleagues have left. But Chris, I hand over to you.
Thank you, David. Thank you, Chair. I'm delighted to present to the board today both an improved understanding of our carbon footprint in the NHS, but also a report setting out progress over the last 5 years. The headline figures are a 16% reduction in our carbon footprints, so those are emissions we can directly control. And for those emissions that we can influence, having seen them go up during the pandemic, we've actually seen them return to broadly pre-pandemic levels, and that's despite an increase in activity. Those improvements across our carbon footprint are across our estate, they're across our fleet, they're across the medicines we use, and they're delivered in partnership, so really crucially through our colleagues in Royal Colleges, through other government departments, and through our suppliers as well. And if I just take a couple of notable actions out of the progress report, we've virtually eliminated the use of certain anaesthetic gases with high global warming potential, such as desflurane. We've seen huge innovation in our fleet. We've delivered the world's first double crewed electric ambulance. And more recently, we've partnered with Great British Energy to invest over 100 million to deliver a triple increase in the amount of solar generation across our estate. That's going to pay back 3 times over, and that will add to the £5 million that we already see in savings each year through existing solar. So that's just 2 or 3 examples. There are many more really, really good examples throughout the progress report that we seek to publish today. And much of that delivery against our ambitions is really through the incredible efforts and dedication of staff right across the NHS. So I'd just like to take this opportunity to say a big thank you to them for their continued effort and support to deliver a greener NHS. Thank you.
Okay, questions, comments? Sam, Duncan, Ravi. Sam.
Yes, if you look at some systems, some areas, advice and guidance can reduce travel to outpatients by up to 60%. And in some systems, guess what? You don't need to go to outpatients before or after have your blood tests. You can get them done in primary care. My question underlying this is, to what extent are you looking at all our policy documents in this instance, particularly on transformation of outpatients, to look at some of these potential green gains. And the second question is, if you sit in a general practice, you will have a pop-up. So we're doing great things on inhalers, but you'll see a pop-up saying you have to have a new plastic spacer every year. And actually, when there was a parliamentary question about this, it was very unclear as to who's driven this process, but it costs millions. But hidden within that question is also what you have talked about, David, which is about engaging people out there. This is very engaging for a lot of clinicians and staff of the NHS. But to what extent do we engage them on a day-to-day basis, and do they see their ability to reach the top of the organisation and see action taken on things like the spacers?
Duncan?
Yeah, so I would just to build on the point about engagement from staff. This is one of the things particularly that really heavily motivates nurses and midwives, particularly if you see that generational shift where we've got a much more climate aware generation in our workforce now, and it's certainly will be one of the strands that we're working on through the development of the nursing midwifery strategy for England. I guess there's something about the pace of adoption, and are we doing enough to drive some of the pace of really good examples that are going on across trusts and make sure that they are adopted? And do we need to do more on a kind of zero tolerance on stopping certain products, for example, where we know we have an impact and will have an impact on cost? And then I guess the risks around some of the other developments. So my understanding is that AI and some of those changes requires a big, heavy input of power. And so I guess the risks for the next 5 years and the work that we need to do in terms of transformation, are we going to replace one improvement with another kind of increase in carbon?
Ravi?
On similar lines, I was struck by the fact that secondary care energy bills have doubled since 2019 to over 1.4 billion. Just made me wonder about whether we are maxing out on all the energy efficiency and solar generation projects that could potentially reduce bills. It sounded like you're doing some through the public sector decarbonisation fund that I think is stopping Plush GB Energy. But are we doing all of them, or are we constrained by the kind of finance available? Because if there is other NPV positive stuff that is there, we should be able to look at other ways of financing this. I'm particularly thinking about the distribution network operators actually as a potential way of doing that.
Magna?
Thank you. So not answering your question, just making a comment about more sort of clinical engagement throughout the NHS, actually, because we're pushing on an open door. And with my CEO hat on, I can tell you about the difficulties experienced. So the first was measurement. People couldn't get through the detail to understand the conversion from sort of pounds to carbon. So that was the first thing. So we actually did a pilot project with Harvard University's Professor Kaplan and Ramana, and we focused on the hip replacement pathway to look at scope 1, 2, and 3 in terms of how much carbon is accounted for the day of admission to the day of discharge for the most commonly done operation. And that's now being rolled out. And as a result of that understanding and working with the manufacturer who produces the hip implant, so looking at supply chain as well, it was very easy to then focus on, well, how do we improve this? What steps do we need to do? Cycling to work, or whether it's switching off the theatres overnight, or stopping the manufacturer sending the implant to Germany for a coat just to come back to England. So all those things are currently in practice, and people are really focused on delivering this.
Right. Glenn?
In answer to your question about access to capital and whether this is constraining our progress, it is. Salix is a good example of that, and as far as I'm aware, when the Salix funding becomes available, it switches on, and then within a few hours, everyone has all the money's gone, and you can't bid anymore. So there's a load of Salix-related projects out there that have not been funded to date. So what's the future of Salix moving forward?
Okay. So I think great bit is you've got lots of enthusiasm here, which is really good. I think quite a few of these are in some ways more prompts for more work and more focus rather than necessarily questions to answer. I would just add a couple of bits as well, and then you can come back on how we take this forward, really. So I think Sam's point on outpatients, I thought the report about 5-6 years ago Royal College of Physicians did, 5% of all cars on the road are going to an outpatient. Staggering figure. Worse, to Sam's point, you know, is that a good use of those car journeys? I would add to Sam's bit on inhalers, wider EpiPens have to be replaced in schools every single year. Does everyone need to wear plastic gloves? Does everyone need to wear a plastic apron? I've never seen what a plastic apron does. Doesn't seem to me to anyway. But the list goes on and on and on and on. Should we have a proper review of those? Should we ask NICE to look at the evidence base behind some of these things and whether or not we really do need to keep replacing everything because it costs a lot of money and affects the environment? For me, the most staggering figure, which we know, but anyway, 27 million of square metres of buildings. So yes, energy efficient use of them, but we don't need probably a quarter, a third, even half of that space. So how are we actually going to exit buildings in order, and using that as an argument for going greener would be good. And then I think really important is, which is a bit Meghna's bit about doing deep dives, but even at the high level, figures 1 and 2, you don't need to answer that now, but I couldn't align the data across the two of them. So don't get into that now, but there's a bit about sort of being very clear on where are there opportunities to improve and therefore what can we do. So you've got lots of enthusiasm. Tell us what we can do next.
Sure. Thank you for enthusiasm. I'll try and bundle a few of those together. So look, staff engagement, clinical engagement is massive. Last time we surveyed, we knew 9 in 10 of our staff wanted a greener NHS, so we know that's there. In terms of focusing on clinical pathways and opportunities, especially around reuse, we've partnered with GIRF, Getting It Right First Time programme. We've done our first greener deep dive there on bladder cancer pathway. We've seen that actually, whilst we save 2,500 tonnes through that revised pathway, we're also reducing the number of appointments, outpatient appointments, faster diagnosis, patients spending less time in hospital. So there's mutually beneficial points for both our programme and the wider NHS in bringing clinicians into this programme. In terms of some of the other points around patient travel inhalers, we published our revised Green Plan guidance earlier this year. It's for the first time sets out a lot of best practice about where organisations such as Jim's and David's, they're referenced, I think, in there in terms of taking action and actually trying to replicate that. We know that there are some high-performing trusts. We know that there are some who probably need to catch up, and it's trying to bridge that gap. Just on the point of capital delivery, there's a lot we can do in our programme to reduce emissions without spending money. But capital delivery, particularly, and I think the paper talks about heat going forward. So we talked about SALIX and the public sector decarbonisation scheme. They are the same thing. They're in high demand, and actually perhaps our biggest challenge in terms of staying on track over to our interim targets and longer is actually finding a way to find financial models and vehicles to be able to deliver some of that decarbonisation. So there's a few challenges there which we'd love to take further beyond this board.
All right, great, really good conversation. Look forward to seeing 16% get to 30% next year. Good. Okay, let's move on to the next one, increasing research activity. So, Lindsay, I think you're going to do this. Yep. Very good.
Thanks very much, Chair. Thanks, everybody. So I'll take the paper as read. I just want to make a couple of points before I hand over to Alex, who's my colleague from DHSC. We work very closely with our colleagues in NIHR and DHSC on this agenda. The paper frames this particular issue within the context of the Life Sciences Sector Plan, but we really do want to focus the board's attention today on the setup of clinical trials. It's a real political focus at the moment. It's in both the Life Sciences Sector Plan and our 10-year health plan, but it was kind of stimulated by the Prime Minister making a commitment in April to move to setup of clinical trials in organisations in 150 days or under. Unfortunately, at the moment, we are only managing that in about 30% of studies that are on the NIHR portfolio, so we have a long way to go. That said, there's a significant amount of work that is ongoing, working through our colleagues in the sector through the UK Clinical Research Delivery Programme, and the paper sets out the work that we're doing there to standardise, streamline and remove duplication across organisations. It also sets out some of the requirements that we've put out to the system following feedback. Vinda Waka wrote to organisations in May asking to increase board visibility and board accountability relating to this. And I think both Alex and I smiled to each other, Penny, when you said what gets measured gets done. We would love to move this agenda to what gets measured gets done, but we do really need this board support to make sure that we are measuring it and then we understand what is happening. So really what we would like the board to think about and give us a steer on today is what more could we do if you think there are areas that we aren't addressing. And if there are areas like using the planning guidance, etc., where we can actually pull some levers, are they appropriate? I'll pass on to Alex, who I know wants to make a few comments from DHS's point of view.
Thanks, Lindsay. And I just wanted to bring sort of perspective from the ministers and the government's perspective. I think just to focus on sort of vision and then why we want to do it and the three asks that the government wants. I mean, from the vision really is that we want research embedded as part of everyday care. And we want the NHS seen to be competitive for clinical research, both non-commercial and academic, but in particular commercial research. And just to flag, commercial clinical trials is the lifeblood of the life science industry, and at the moment that isn't working. Why we want to do it? We want to do it because we want to bring new treatments to patients faster. We want your support and the workforce so that they can be more productive and we can free them up to do tasks that in reality matter. I know the Minister is very concerned about this. In fact, I spoke to the Minister yesterday and he said, Alex, do you want me to come along to the board to really emphasise this? So it is a very high political agenda item at the moment, just to reiterate that. I think the three key asks from me and from the Minister really are, first of all, can we really make sure that research is embedded as fully as everyday care and it's not seen as an add-on or separate from healthcare? Secondly, I think, reflecting what Lindsay's just said, if we can get NHS trust boards to actually measure the 150-day metric as well as the other key performance indicators we've got, that will make sure that performance in commercial trials gets delivered. And then thirdly, we have set out a number of policy guidances and recommendations centrally, and if we can embed those more effectively, we are really keen, and I think that from our perspective that will really help deliver some of this. So those are the three asks. Thanks.
Okay, thank you. We've got Sam, Mark, and David. Okay, Sam.
Yeah, so one of my hats is an honorary professor of primary care at Queen Mary University, and when I see the change in research opportunities, in other words, the capture of the 2 million database in primary care, the discovery project that connects it to the acute sector, the opportunities are massive. But we still have a research base which very much focuses on hospital. We haven't managed to shift it towards the system, and it plays, I think, to Robert's point earlier on about the drug companies and the risk of them exiting because of costs. Have we done enough to sell the research opportunities, particularly to the drug companies that are unique in this country?
Okay, Mark.
So I had a few points. First, welcome the paper and the conversation that we are having. Really important area. There's a few things though. One, I was unsure reading the paper about what the delivery vehicle is going to be for these priorities. Yeah. It's a little bit mixed, I think, because regions, of course, will need to play a role at some point in the future. But given the changes going on at regional level, I think just putting our focus on strengthening the capability and capacity at regional level, I think will mean that we don't realise the pace of change that we're going to need to see in this particular area. Final point was around cost recovery. Because it is important to obviously make sure we're recovering costs, but that will not give us the growth that we're going to need to see for commercial research. And I think that's something that we just need to think through, not be silly about investments, but really thinking ahead about where we know there's going to be likely growth in research activity and making sure we have a model that's going to support the increase at the pace they have an opportunity to go at. Thanks.
David?
Yeah, I mean, really welcome the paper. I suppose just to remind everybody, and the figure keeps changing, but every pound invested is an £8 to £10 return. To Mark's point, it doesn't, to the UK PLC, it doesn't necessarily fall in the place where you spend the money, which is part of the challenge. Just to Sam's point, I chair the North London Clinical Research Network, which I've done for 10 years. The fastest growing research is in primary care in terms of number. So there's opportunity there, but you're absolutely right. We need to harness it differently and think differently about how we approach it going forward. And I suppose two final things. One, there are still organisations out there, and I understand the challenge, where they are not spending money on research allocation to save money overall, even though the letter's gone out from colleagues, even though we've tried to reinforce it. So we need to find a different route to make that message stronger. And very finally, I had a good conversation with Lucy last week, Lucy Chappell, and I'll support her with the Shelford Trust to seeing whether we can benchmark some opportunities to speed up some of this 150-day target work.
Okay, so just because it falls within your remit, David, the question about should we be measuring this and looking at that variation across all providers, is that something we could add even to that master performance?
Yeah, I mean, it will be relevant to a proportion of providers, absolutely, and research active providers do measure it, but probably even not as frequently as they should do. Organisations like mine, like some of them represented down the table, should be looking at this as they are the 4-hour access target, to be honest, if we're prioritising this. So, yeah, we'll take that away and think about how best we can do that.
Okay, great, thank you. Okay, so I've got Robert, I've got Elizabeth, I've got Megan, I've got Louise. Right.
Yeah, well, there's lots of great stuff in this paper, and it's very welcome, and congratulations on what's going on. I think picking up on a couple of things, so picking up on Sam's point, I think the Health Data Research Service plan is brilliant. I assume that'll include primary care data, and this links on to Open Safely, which is on the menu, but we're not discussing it, which is a great way to ensure that data is really fully accessed. This is focused on phase 3 trials, and I understand that, and it's very important. But if you think about 7F and partnering with industry to drive growth and innovation, early phase trials, I would say, are also extremely important. And I don't think I saw a single mention of the university in this paper. And if we want to drive innovation and industry partnerships and everything else, we need, on the one hand, to have patient data readily available. That's what industry wants. But we need university research to be drawn in, and then we need life sciences clusters that bring those three sectors together, which is what is going to drive some of those early phase trials to drive novel therapies, because as I'm sure you know, 50% of the drugs in the pipeline are not small molecules, they're advanced therapies, biologics, cells and genes and all that, and that requires these NHS, academia, industry clusters to be really thriving.
In part, David said what I was going to say just about the return on investment being compelling, but not always the cashable savings arrive in the NHS, so the engagement can be muddied. But I had the pleasure of meeting with Lindsay and Vin about this topic, and what I was also surprised by is the amount of work that actually goes on, but the lack of cost recovery. Even though the providers have actually done the work, they don't follow through to recover those costs from commercial contract research. So there is an opportunity there for us in the sector, and it's on our agenda for the 9th of October or the 8th of October, when we bring the CFOs together again. Okay. And it's gone out in a kind of these are the things we should be looking at. And with Lindsay, we're trying to identify which providers are doing the work but not recovering the income, which is surprising, which just makes me think it's not linked through to the board or execs, or something is odd that's going on, because for us to follow up on.
Magna?
Thank you. Thank you for the paper. So I completely agree that we have to make it clear that research is not an add-on. It is part and parcel, because there's clear evidence that research active organisations have lower mortality rates, and there's a lot of research in primary care actually. So I would support adding the metrics related to research to the board frameworks. the point is, it's not just about the time taken to set up trials. It should also be about access to research for diverse populations and what percentage of diverse populations that come to clinic have that research, exposure. That's the second thing. And third thing is standardizing pathways is really good. It'll cut a lot of duplication and number of days taken to set up. However, if you get organizations to do a process map of that pathway, you will find specific delays at key points, and one of them being pharmacy.
Yeah.
And that's not because they are not quick, it's because there are resource implications. So I think working through those challenges will be key, and they'll be different at different organizations. But I know that pharmacy is a key issue.
Louise?
So I think we also need a kind of corresponding narrative for the public and for particular groups about the importance of taking part in research, and I don't think people associate research with primary care, for example, and it's kind of how do you change that expectation? Sorry, Sam.
Yeah, that links into the app allowing you to participate and so on. Tom?
So I come from a position of having tried and failed to set up a commercial clinical trial in the NHS, having some direct personal experience. I didn't see anything in the paper that I saw as fundamentally changing the paradigm that we're currently in. I don't think there's any question that if you ask any leader in the NHS, they'll tell you that they think research is important. So just telling people that it's important, I don't think it's going to particularly change anything. I think we need to have a discussion on the table about two things. Firstly, some clearer incentives. So this point about cost recovery, at the moment, I think the mindset for most NHS organisations is that this is yet another thing to do, and it will involve some cost as opposed to being an opportunity to generate some income. So I think shifting from this is a cost centre to this is an income opportunity is the most significant shift that we can make, and we need to construct some incentives to actually make that shift occur. And that also means that the incentives have to be understood in the wider system. The second thing, and I think we should explore this with our partners, is that we currently approach UK assets like UK Biobank and presumably HDRS on the same basis as kind of global public goods. So any researcher anywhere in the world can access UK Biobank. Given the kind of pullback that we're seeing from the pharmaceutical industry, I wonder whether it's time to explore whether there should be privileged access to those UK assets for those companies that are research active in the UK, because at the moment we're making them available on a completely equal basis to any company anywhere, regardless of whether they contribute to UK life sciences or they don't contribute to UK life sciences. I think we should explore that as a possibility.
Paul?
I just reflecting on this being a cost and not seen as an investment which can get a return. I think in probably the last 15 years, many universities have made that shift where research was sort of a hobby that some people took and was a cost because it kept you away from teaching, to the universities recognising that they can get some return from this. But that is a change in not just mindset, but a change in organisational pattern. And so I think we could go to not just the universities that have done this well for 50 years, but universities that have learned how to do that change and to transfer that learning into the National Health Service, because it's quite recent in these institutions.
Okay, so this has turned into a bit more of a workshop, which I think is great. You've got I think I've written down quite a few of them. You will have done lots of really good ideas, thoughts, inputs. I think we have agreed that we need to measure this, and I think that includes measuring what happens, maybe some stuff around finances, certainly how much is done in primary care, wider settings. We don't have time for you to come respond to it now, but I think take all these things away, come back with almost a beefed up version of this, including some choices, like Tom's put a few slightly provocative choices out there. There are a whole wider set of actions for NHS England in the life sciences sector plan So what I propose that we do is we'll bring it back with all of the actions and include this sort of, I guess, set of wider things that people have raised across the table. But thank you for bringing that.
Thanks to everybody.
Very good discussion. Okay, I'm doing very badly on my timing. Next item is for us to accept without discussion the improved access data and analytics. I do actually have quite a few things I'd quite like to raise, but I won't do that. Are people comfortable to accept that set of directions? And we might pick up separately some of the questions that come from it. Okay, so we have some questions from the public, which Jim and Duncan and Glenn are going to respond to. Duncan, do you want to go first with your two questions?
Yeah, so the first one is a question around the Supreme Court ruling on biological sex, which happened in April, and the question is around what is NHS England doing about this, and I think just to say that we are reviewing our relevant policies and procedures to make sure that that is aligned with the ruling, but we do need to wait for the EHRC, which is the Equality and Human Rights Commission, to update its code of practice for services, functions and associations, which will set out the legal framework of how services are delivered in line with the Equality Act, and we need that available before we can make final decisions about national policy. So the updated code of practice will be published shortly, subject to parliamentary approval, and we will therefore, once that has been done, update the guidance and publish that. So we're kind of waiting on that timeline, essentially. And then there was a question, Penny, about the graduate guarantee for nurses and midwives, which was launched in August this year, recognising that some student nurses and midwives that were qualifying this year were struggling to find jobs. The government announced the graduate guarantee, which essentially we are working on, and working the regional teams and across trusts have been really leaning into this to make sure that we support student nurses and midwives to find roles, not just in the NHS but more broadly, because there aren't just vacancies in the NHS, there are vacancies across social care, the independent sector and other places, and so we are trusts are supporting measures about recruiting ahead of turnover, which we know happens every year, making sure that they're using vacant roles creatively, and we've also made £8 million worth of funding available specifically for midwifery to convert temporarily some maternity support worker roles which are vacant into midwifery roles. The guarantee is for this year. Clearly there is work that's going on the new 10-year workforce plan and the nursing midwifery strategy, which will look at future years.
Okay, thank you. Jim, voluntary redundancy for ICB staff?
Yeah, we touched on this briefly earlier. So a few weeks ago we met with new cluster chairs and chief execs and talked through where we are, where the potential is for a plan B if we don't reach agreement with Treasury. We are actively in discussion, as I've said earlier, with Treasury, and hopefully we will resolve that soon, but if not, we'll have to revert to plan B. That's probably 2-3 weeks time. I think we'll have to draw a line, and then at that point we'll engage again. Every ICB has a plan that they can enact. It is limited by the resource that they've got, so it would be more of a stage process. The benefits would be less and slower than anticipated, but we will activate that as soon as we've reached a point of either concluding the discussions or needing to revert to plan B.
Okay, thank you. And Glenn, questions about regional differences in terms of how vacancies are managed?
Yeah, so links to the question Duncan's already answered about the graduate guarantee and a who does what question in the new framework of the NHS. So we set out in the model region blueprint on the 8th of September, and that's the first version of that. We'll do an updated version. That's a high-level mandate which sets out the functional roles of regions, but also is to ensure consistency across the regions, particularly on this issue. They will take the role of strategic workforce planning at regional level, and as part of the oversight framework we will be monitoring the performance of individual provider organisations but also ICBs. We will do a further update of model region when we've completed the 10-year workforce plan, which will reinforce some of those responsibilities.
Okay, thank you. Does anyone have any other business they'd like to raise? Okay, well, thank you all very much. I think it's been an extremely broad-ranging conversation, and we will take forward the various actions highlighted and look forward to the next time. Thank you.